Are you a leader or are you a follower? You'll understand more about this question in today's episode as Julia DiPaolo, a physical therapist, talks with us about the difference between evidence based and evidence informed practice. Hello, friends. This is Lynn Schulte, and you are listening to the Birth Healing Summit podcast. We are here for meaningful conversations that will transform the way you work with pregnant and postpartum clients. Whether it is a new perspective, tool, or technique, you'll be able to implement it into your practice today. I invite you to sit back, listen with an open mind, and grab the golden nugget today's guest has to offer. Now let's get started. Welcome to this episode, everybody. Today we're going to be talking about evidence-based versus evidence-informed, and I brought my good friend here with me, Julia DiPaolo. Julia is a physiotherapist from Canada who's turning physical therapist here in Texas. And Julia,
Soon.
yes, we hope. She's trying to get all of her information,
Credentials.
credentials together
Mm-hmm.
and sit for the test again. So this is just
Yep.
crazy. So good luck with that. Welcome to the episode,
Thank
Julia.
you.
Thanks for being here. So
Thank you.
everybody,
It's so much fun.
I know we always have a great time talking. You've been a part of my birth healing summits in the past, and our conversations are always so juicy, I think. So but Julia has, for those of you that don't know Julia, Julia has presented several times at the American Physical Therapy Association Combined Sections meeting and also in the Canadian Physiotherapy Association as well on diastasis recti and pelvic floor. So um, today, Julie and I are going to talk about evidence-based versus evidence-informed. So Julia, what's the difference between those two?
Well, it's funny. We chatted about this a little bit loosely, and I went and I looked it up this morning, and the of course the experts can't agree. So I so I'm going to tell you what I think it is, and a little bit about what I found online doing a quick research. And anybody can look it up. The difference between evidence-based practice and evidence-informed practice. And for me, evidence-based practice is. Whoop, I'm going to lose my microphone. Evidence-based is really basing it on the research, right? So they've done research, they've assessed it up the wazoo, and if we want to take pelvic floor, for example, then we can look at Carrie Bow's stuff back in the 90s. Hold for 10 seconds, repeat 10 times. We have evidence based knowledge of this is how we do pelvic floor muscle training. Of course, we don't always all do it that way because we do more evidence informed practice where we look at what they've done in research and we look at the person in front of us and go, well, I need to tweak this like this. Or the last 20 people I've had, I've done it this way, and this is working really, really well. Or in evidence informed is much more looking at the body of research and going, well, that applies so far to this degree, but not quite exactly. So let me add this in and let me add that in and what I know from my practice and what the person wants and what their body is telling me, and then going from there. So using it as a background, our education and all the research that's come about, and then applying it to this specific person. But it's we're never going to have that very specific person that is from research ever. And so evidence-based practice seems very cookie cutter to me, whereas evidence informed seems much more open and uh, accessible to doing all kinds of different things that haven't been quote unquote proven in the research yet. So if we're looking, one of my favorite ones is the parachute one, where they actually haven't done a randomized control trial of jumping out of a plane with a parachute. And so we can't say that that's evidence based because they actually haven't done the randomized control trial or the gold star for it. And so, but everybody knows jumping out of a plane with a parachute is a much better idea with a much better outcome. And we don't need the study for it. So there are things where in clinic, we just know they work and we don't need to study them. And there's things that they've studied and we can then just extrapolate to our patient population or to everybody else. And the other thing that really drives me bananas is I've been in practice a very long time. And now that I'm studying for my exam again, it's driving me crazy because some of this stuff is so outdated, but it's evidence based. But pain, for example, what we learned for pain 25 years ago in school is not what we're doing in clinic with pain anymore. And so that's also, are we evidence based anymore? Like, but they've come a long way with their research. So now we are. But then you look at pelvic pain and how long, like 10 years ago, when I started pelvic health, we didn't have any evidence based research. We had evidence informed from what they were doing with the other persistent pain people. And then we were trying to apply it to our pelvic pain patients and population. And so there's this fine line between the two, I guess, where it's we really kind of get a little bit of creative license with the research to apply to each to either our caseload, our population, our person in front of us that's just different from everybody else.
Right. And I loved when we were talking earlier, you were talking about how, the research actually takes 400 people and
Yes.
distill it down to one person. And this is what works for that person. Well, we don't really see that person in the clinic.
No, they don't exist. It's a median. It's an average or a median of a person. And so this person's arm, this person's shoulder, this person's knee, this person's brain, and this person's baby, this person's pregnancy, like it's just a mishmash of all the different people. So to be very, very rigid with evidence based, I find is very rigid. And so I don't like that approach as much as evidence informed.
Yeah. Well, I want to give a huge shout out to all those people that are the researchers who
Oh
are
yes.
trying to qualify and quantify and help guide us in our practice, because it's so needed and so valuable. Um, and yet, I love what you're saying is that we can use that research to guide us, but it shouldn't be the end all be all
Yes.
that we put our practice, we make the foundation of our practice. Is that what I want to say or not?
I would think so. And the what I my experience is always the clinicians come up with questions and then go find a researcher to ask them to do
Yeah.
it. Or clinician has a question that doesn't get answered, so they go back to school and get it answered. And so we're getting the questions in clinic because we're dealing with the people over and over and over again. And I get it that we have to prove things in order to say that they're 100% true. And that's fantastic, and huge shout out, huge respect to all the researchers that have done stuff. Like with when Diane Lee was doing the research on diastasis, it took 6 years to get her studies published because she had to what she saw in clinic and then she translated it to ultrasound, but then she had to prove that what she was seeing on the ultrasound was actually what she was thinking she was seeing. And so that took another few years. So she and Paul Hodges did amazing work and finally got it published and kind of finally got it, this is evidence based. But before that, that didn't mean we were waiting that 6 years. We were still treating that way until the evidence caught up to us. And that's my other favorite quote is if you're ahead of the research, you're a leader. If you wait for the research, you're a follower. And so it's really important to me that and for somehow even in my practice in Belly's Inc. and everything I've done with diastasis, we always seem to be kind of just a little bit ahead of the research.
Mhm.
And it's a tough place to be because everyone wants you like they want the proof that what you're doing is going to work and you don't quite have it just yet, but
But
staying static in what we know is not also
but we do
a good thing.
have it in our clinical practice. We have it in our results,
Yes.
right?
Yes, and
And
that's where the evidence informed comes.
right, because that's the empirical evidence, right?
Yes.
That what if I do this on my clients, I'm going to talk about the open birthing pattern because that
Hmm.
is I'm being a leader out there. I'm saying, hey guys, we know that the bones of the pelvis open up to allow a baby to come through. I'm
Hmm.
here to tell you that they don't always go back into place. And when I do X, Y, and Z, my clients have a much better pelvic floor muscle contraction. Their back pain goes away, their pelvic pain diminishes. There's massive, massive evidence in my clinical practice in how my clients are responding to what I'm
Well,
doing.
in your course is a perfect example. So let's compare our two courses. So my course, I spent time, I went to all the research, I pulled out all the references, I have a whole list, I have a whole book of references when we did the pregnancy, when we authored the book, Pregnancy Fitness. And so it's evidence based, right? So I made sure that every line had a reference to it because that was important, and that because we were evidence informed, I wanted to have that base behind it so that people would acknowledge it. Your course is a perfect example of evidence informed. And now we know from when we did the CSM presentation, we went back and found all the references for people if they want it to be evidence based. But it's evidence informed, and you just didn't bother putting them in the course. You spent your time on teaching us the techniques. And I personally love that because it's the techniques in the hands that are going to change the patient, not a study in my, in my binder that's going to change how my patient feels. And
So
so that, I think, is a good kind of, when we're talking about the difference between evidence based and evidence informed, is we've got all this evidence that proves to a biological plausibility what you're doing is working. And we have the patients, and we have the empirical, and we have the clinical evidence. What we don't have is someone who did an RCT that did this technique versus that technique, and this technique worked and this technique won out. And so we don't have that hardcore evidence, but we
yeah,
have all this other research evidence of all the positions. And we spent a lot of time going through those studies. And
yeah,
let's shout out to Lori, because she had the more difficult part of the
right.
project where she had to do the actual birth. But we found all the evidence that showed that the pelvis
Yeah.
changes during birth. And all we're suggesting is that it stays open after. And now we just need a researcher to quote unquote
Proof-
prove it
Right.
so that it can be evidence based versus just evidence informed. Does
Right.
that make sense?
Yes. Well, a couple of things I want to say there.
Yeah.
Julia was just talking about Lori O'Neill, and Julia and I presented in 2021 at combined sections meeting for the APTA. And we also did Canadian too, right?
Yeah.
So
Yeah.
in the never ending birth, common postpartum patterns in the pelvis. And we did all the research, and we found that, yes, we know evidence shows us that the pelvic bones move and change based on the position a person is in.
Mhm.
And but there was no evidence that we could find that proved that the pelvis remains open afterwards.
Yeah.
And so that, and so when I first found this pattern in the body, I was seeing it in my clients, and I kept palpating and feeling the pelvic bones in these different positions. And then I went and I looked at the research. I looked at what was being said of what happens to the pelvic bones.
Mhm.
And I, used the biological plausibility that, okay, we know the bones move in this direction. Guess what? I'm still finding them there afterwards.
Mhm.
If I do this, this, and this, I change it, and the function of their pelvic floor increases dramatically.
Yeah. And as you know, kids don't put anything back where they found it. So it's beyond biological plausibility. It's hard fact. Kids don't put anything back, not your uterus, not your bladder, not your bones, not nothing. Nothing goes back. And so for me, it just makes common sense. Like, it's not even like, and I remember sitting in your course the first time and just like smacking my head going, oh my God, like this, it's just common sense that the body's not necessarily going to go back to the way it was pre-birth for everyone or for anyone. And everyone's going to be that little bit different. But yes, it's the biological plausibility is so high. And again, we just need someone to actually quote unquote prove it so that it can be evidence based versus just evidence informed in my definitions
Yeah.
of these words.
Well, we know we have a ton of empirical evidence, not only with myself, but with my students now getting the same
Mhm.
results as well with those postpartum clients. So,
Oh
um,
yeah, it's
you know,
amazing.
yeah, I really want to again give great respect to the researchers, but I have to say it drives me nuts because you have to only research one thing and do it one
Oh
way. And, like,
yes,
so it's so hard for
and
us to,
and
I think when we're talking about this open birthing pattern, we may be talking about millimeters of
uh-huh.
movement. And will that
Yes,
really show up in
yes,
however we choose to measure this? And I am on a mission to get this somehow documented, somehow researched. But it,
yes.
like Diane and others, it may take us 10 years to get
Uh-huh.
there.
Oh, it will. And and then it's to change practice after that. So even when we do have research, I mean, I found research from 1993 about birthing positions. Do you think they use those birthing positions? No, this is 30 years ago. 30 years of really good, solid evidence, and they're still not using it. And so, and that's also my little beef about with the research is how long it takes for it to come into play when
Yeah.
we already know what's working in clinic, and we just need more hardcore evidence of it. And they with the research portion, and I was going to do a master's at one point and a research study, and they kept distilling it down to like 1 or 2 data points. I'm like, this is no longer clinically relevant. And so I ended up not doing the study because I just didn't feel like 2 years of my life was going to add to any body of knowledge that we already knew as clinicians. And it was on the shoulder and neck thing. I can't remember what it was, but um, it's so fascinating to me how hard it is to do because you can't have too many variables. So
Right.
when you're looking at, really focusing on evidence-based practice, you're looking at a very limited number of variables as well. And so find me a person like, I mean, I've treated 10, 12 textbook disc bulges
Yeah.
a la McKenzie, NDT protocol, and everyone else is just a little tweak different, a little tweak here, a little this, a little of that. They get better this way, they get better that way. So and that's very well researched treatment protocols, and even that has so much variability to it. So I think, and I wonder if that's where some of this argument on evidence-based and evidence-informed comes from, where I've seen definitions that look very similar in like evidence-based to me is really the research says yay and it's yay. The research says blue is blue. Whereas evidence-informed involves the client, involves the therapist, involves all the clinical what's that word? Empirical evidence
Yes. Yeah.
together, right? And so I find it very, very difficult for me because at the end of the day, the only thing that really matters to me is that the patient thinks that they're better,
Amen,
and
sister.
and, and that what we did was somewhat helpful in either guiding them or helping them or doing something that made a difference in their life, in their pain, in their
Mhm.
movement, in whatever they came to us to see. So that's so I think I'm I'm not a very good person to talk about evidence based because I my number one goal is always what are you here to see me about and how do we get you there? And are we there? How close? That's always my question. How close to your end goal have we come so far in this treatment? What do we need to do to get there? And that's when we pull out all the stops, right?
Yeah.
All the different things we know, all the things that these awesome researchers have proven for us, and then all the stuff that they can't. Like, can they even prove? Like, even what is it? The Stork test? There's
Yes.
so much argument on that test, and
Yeah.
manual therapy,
Well,
like
because that's
so much argument.
yeah, the start text is millimeters of movement in there,
Yeah,
and to be
yeah.
able to differentiate yay or nay,
Hmm.
um, yeah, it's
And you're
challenging.
going to be in that boat with the open birthing pattern. It's
Well,
such a
you know,
it's going to be difficult to measure. It's going to be really hard.
yes, I do agree, but I think, we've talked about this. I have very large hands, and I am
Yes,
surprised at, where those ischial bones start out
yes.
when I'm palpating to see if there is a splayed open
Hmm.
ischial pattern in there, the open birthing pattern, and then where they close out to. So, I mean,
Hmm.
in
Yeah,
my hand, it's drastically different. And I'm just
yes,
like, how can we best measure that?
yes,
And
yes.
so
And
we
qualitatively we can because the patient gets up feeling better. But
right, right.
but then
Quantitatively, can
but
we?
yes, and that's the big question, right?
Yeah,
And I notice it too. And my favorite thing is when, you feel it splayed the first visit or second visit when you're doing it, and then they come back for a follow-up visit and it's no longer splayed,
yeah,
right? And so you're looking at something else and just moving forward, and it stays. Like it's
yeah,
not something that just keeps going back and forth. Um, and so that's also in my little brain how I measure it. But
Yeah.
I mean,
Well, and so we've talked because, I'm all about like, how can we document this? And Julia's my researcher friend. I have to say, I'm going to admit and be personal here. I do not have the critical thinking, analytical brain. Like I read
yes, you do.
something, yeah, but you have much, much better. You can really discern and distill out because I'll read the research and I'll be like, Julie, what's this trying to tell us?
Oh, okay. Yes, thank you.
And so
But
that's and everybody, that's not where my love lies in reading the research. And I have a greater appreciation for the research ever right now. And so I do understand its importance and I am reading it more. And I have to say I am enjoying it just a little bit, but not a lot like Bill. So, but coming back to, you and I were talking about how do we how do we show
quantify.
this? How do we
Yes.
prove it, right? And so one of the things we were talking about is because there's such a dramatic difference in the quality of the pelvic floor muscle contraction.
Hmm.
And so one of the things we were talking about is maybe we did ultrasound imaging pre,
Hmm.
where the bones
Yeah.
are, and then post, and maybe we can change the amplitude. I don't know if we would be able, you said the sound head wouldn't be able to determine the distance between the ischiums or the tailbone.
Yeah. So we have trouble with the sound, like with the wide we can measure, even with diastasis, right? Nadia Kashwani did some research with that with a pad to get a little bit wider. So I don't know that we could get that accurately with an ultrasound head. We can look at some, and again, we can't test strength on an ultrasound. We can just test movement, right, of the pelvic floor, whether it's going up, if it's lifting the bladder, what's happening. So we get kind of information from the ultrasound, and we can also look at like releasing, if they're better able to release. We can look at symmetries side to side. So the ultrasound does definitely has some value, and it's interesting because when I first started treating, I am a pre-post kind of person. I want to make sure what I'm doing is doing something. So even though when what I learned from you was all external, then you go internal. I always go internal first, and then go and play on the bones, and then come
Uh-huh.
back and see if their their pelvic floor muscles are better, and they always are. Like it's just the most insane thing, and in my brain, and you just can't improve strength that quickly. Like strength doesn't improve in 30 seconds or 3 minutes. Like it just doesn't. You don't improve strength like that. You can only do that if you've changed the alignment or the coordination or something,
Well, we're
knowing
changing
more
that.
neurological.
We're changing the length tension curve
We are
of
changing
the
that length
muscle.
tension curve, and that is hardcore science. I can pull up a 1965 study. Gordon on a length tension curve, and if the muscles are too long, they don't work well. If the muscles are too short, they don't work well. And when they're hunky dory, Goldilocks, they work best. We have that data. That's
Right. And
hardcore.
and so that's really what we're seeing and feeling in the clinic,
Yeah,
right? Is that
yeah.
these bones we're sensing and feeling in our hands that the ischiums are splayed apart, putting
Hmm.
the pelvic floor muscles on stretch.
Yeah,
And we assess the pelvic floor muscle strength, and it's literally a 2 out of 5,
yeah.
right? And we bring the bones together, get them back into their more normal position, and
Hmm.
it instantaneously goes up to 3, if not 4 out of 5.
Uh-huh. Yes. Is I haven't had a 5 out of 5, but definitely
Yeah.
4 out of 5, 3 out of 5, easily, and different, and they feel different. They connect
Yes.
better, they feel the movement better, they have a better proprioceptive awareness of what's happening down there as well, which is also kind of fascinating. That the yes, there's and that's why it's so important for me, and why I wanted to do this podcast with the evidence informed, because I it breaks my heart when people kind of are so uh, blinders, right? Everything has to be evidence based, and our we have so much knowledge in our hands with these bodies, and to to dismiss something that's not hasn't been proven yet by the science, then I really think we're limiting ourselves as therapists, and we're limiting our patients' abilities. and there are times where I've done the closing the bones, and it had a mild change, and then I had to go and do something else. But
Mhm.
when it works, wow. And to not and to it really it really breaks my heart. And I don't, and again, caveat, I don't do my own research because I didn't like how it's set up. But it's so important to have everything, like just a little bit of everything, where we have that little bit of our clinical experience where we're seeing that result with the patient. And then in your particular case, you saw it over and over and over again, and then you taught two people, and then they saw it over and over again, and then you taught more people and more people, and then people like me come along and go, we have to prove this. We
Yeah.
have to, we have to prove this. We need to find that kind of balance of where everyone will be content that there's enough evidence to say this should be standard of practice, right?
Yes.
And
Oh my
when
gosh.
the same as we do the palpation, like the
Yeah.
3 o'clock, the 9 o'clock, when we're going all
Well,
around the clock, and everything else we do in the pelvic floor, why aren't we checking that these bones have the ability to do what they normally do, move in the way they normally do, and they're not
yeah.
stuck somewhere? I mean, we would
Well,
do that on a knee or a shoulder or a finger or a wrist.
oh my God, Julie, you just got me so excited with this idea that this checking the bones and getting them in their proper place is standard procedure
Mhm,
for intravaginal work. Like
mhm,
we need to be doing the bones of the pelvis before even going in intravaginally to try to make change
mhm.
in the
Although
muscle.
I'm still gonna go in first because I
I
need
know.
to meet
I
with you
was just thinking
post-test.
that. Yeah, you're still going to go into this. And that's why I said when we're trying to make change, when we're trying to treat the muscles, we need to treat the pelvic bones prior to doing that.
Mhm. Oh,
And
yeah,
it's just, that needs to be standard of care.
yeah. Mhm. And it makes sense in my head, right? It makes sense that we would assess every component of the pelvis. Like, these muscles attach onto these bones.
Right.
Like, it's not in my head, I'm like, it's not rocket science. That's why I was so mad that one time in the course. I'm like, it's not rocket science. Why is this not common sense? Why is this not standard of practice where we're checking everything else? So we're checking the labia, we're checking the skin glands, we're checking everything. We check for prolapse. Why aren't we checking that the pelvis itself has the pliability, flexibility, mobility, stability, all the things it needs
Right. Yeah.
to actually have full optimal function? Isn't that our end goal? And
That's our job
yeah,
as therapists.
yes. So
Right.
now, and all these people listening, we have to get people who are either researchers themselves or know people who are researchers. So, because I know there is a group of therapists that will not do a technique unless it's 100% evidence based. And it kills me, but that's their choice and that's their prerogative. And they still, and, oh, who's it? Is it Anthony who says, I won't argue results, I'll argue
Reasoning.
your reasoning. That's it. Yes, which I agree with 100%.
I love
And
it.
I'm totally good if someone wants to come up to me and say, Julie, it's not because you're approximating the bones, it's because of this. I'm like, sure, whatever.
Right.
Did my person get up off the bed and walk and bend down and squat and pick up her baby without pain? I'm good. You call it what you want.
Right.
I'm not attached. I'm not married to any name of a technique or any specific technique. I am married to getting these people better quickly and easily, and not without all this hoopla. And the quicker the better, and the more efficient the better. And
Right.
getting them back to, especially the moms, they don't have time.
Yeah. Well, and I talk about quicker and better. To me, when we have, and this is one of the concepts I teach in my pregnancy course, is that if a person who's pregnant comes to you with pelvic pain and it's a subsequent pregnancy, you gotta check for, and the number one question you need to ask them is, did you have this pelvic pain prior in the earlier pregnancy? And if the
Hmm.
answer is no, their pelvic pain most likely is coming from the open birthing pattern of the pelvis. And when you close up those bones and get them back
Hmm.
into a better position, their pain goes away in one session.
Yep. Yep. I've had that happen too many times to even to this is where I get mad that I didn't think of this myself. And I'm like, really, really, I couldn't come up with this. Really, like it's such common sense in my brain. It blows my mind. But
Yeah.
yes, and agree, right? Like, and then the my favorite is the the girl I did for the case study who had the ramus pain, and just
Yeah.
like going on those bones, right? Like just approximating those two bones, and
Yeah.
boom, no more adductor pain. Like it's I mean,
Yeah.
we need someone to quantify it, because I see it in clinic, and and again, you can argue the reason,
I,
but you
I,
cannot argue those results. You just can't.
well, and it was fun for me to have one of my students reach out to me and she's like, Lynn, I cannot not see this anymore in my clients. Like,
Right?
I see it all the time now.
Yes.
So, oh
Yes.
my gosh. Well, Julia,
Agreed.
thank you so much for your time. Thank you for
Oh,
sharing your
anytime.
knowledge. And I agree with you. I hope, my goal in my clients is or in my students is really to help people get out of their head and into their hands and
Hmm.
feeling what they're feeling in their body. And
Yeah.
so I think that's why I don't spend a lot of time on the research in my courses, because I want to teach you the techniques that really work. And just like
Yeah.
we've talked about here, the results are undeniable. And
And it works. And I don't. I love research. I really do.
I'm
And we
starting
need
to.
it. And, and we need it as our base. We
Yes,
need it as our foundation.
absolutely.
But in a class, when you have such limited time, and it's getting harder and harder to get people out for 3 and 4 day classes. And so if we just give them a list and just focus on the techniques, like we have to also, as therapists and professionals, do some of our own research and
Yeah,
check what's going on, and be aware of what's been published, and what's happening in the world of research in physical therapy and all the stuff that we do. But and I love CSM because they do have those
yes.
references. So it's almost a cheat sheet, going to CSM and then like taking
Yeah,
all the references they do, and then I go and find them and read them, and I'm like, ooh, that's awesome. Ooh, that's awesome. Ooh, that's awesome. And same with when I go to courses, it's nice. But at the end of the day, the research isn't going to treat our patients, our hands are. And if we don't have the techniques in our hands, then therapeutic alliance is huge. But if we don't have the techniques in our hands, then our results aren't going to be as impressive, right?
yeah,
So I love that it didn't. And as someone who loves research and put all that research in my own course, I was not offended whatsoever when I went to your course and you didn't have them listed. I thought it was hilarious. And of course, that's where Lori and I were like, yeah, we got it. We got to do this. And you basically said to me, if you want the research, go put it. I'll post it. Just you go find it.
yeah,
So we did.
yeah, yeah.
And then we
Awesome.
dragged you along with it.
Yeah, I know. Yeah.
But I
So
think I think it's important for people listening to just, you know, trust your hands, right? Trust in the
yeah,
techniques, and trust in the feedback the patient is giving you. And then you'll be ahead of the research.
yeah. Be the leader. Be the leader,
Mhm.
like me.
See you later. Yay!
And please start looking for the open birthing pattern in the pelvis. Please, please,
Yes,
please bring that into
that's
your awareness. Let's make it a SOP for pelvic care.
right.
Yeah,
That would be amazing.
yeah.
So
Awesome.
amazing.
Well, thank you so much for your time, Julia. Thank you, everybody, for listening in. And let's keep that evidence based, but let's not let that stop us from doing really good care with our clients and doing what the body in front of us needs. So thank you, everybody. We'll see you all on the next episode. Here's to smoother births and faster recoveries. Take care, everybody. Bye-bye.
Today's podcast was brought to you by the Institute for Birth Healing. To discover more, visit instituteforbirthhealing.com. To claim $50 off of any online course, use coupon code PODCAST50 at checkout. Till next time, I'm Lynn Schulte, founder of the Institute for Birth Healing.